Hi, I am Anvesh Naramiti, a medical resident at St. Vincent's Hospital. I would like to thank ACP for giving me this opportunity to present my case on this platform. Let's jump into the case. 62-year-old female non-smoker with significant past medical history of hemochromatosis, alcoholic cirrhosis with MELD score of 15, child-picks score of 7, and idiopathic hypoxia from over a period of 1 year requiring 3 liters of oxygen at night, presented to us with severe shortness of breath from last 2 weeks, which is gradually progressive, associated with productive cough with white mucoid sputum, and no associated wheeze, fever, or orthopnea or PND attacks. On evaluation, she was hemodynamically stable except for hypoxia to 80% on room air in the sitting position, and her saturation was 86% in the supine position. On physical exam, patient has no stigmata of chronic liver disease. On auscultation, she has a normal S1 and S2, and with decreased breath sounds in the bilateral lower zones without any wheeze. We started her on high flow oxygen and her sats are barely touching 90 to 91%. On lab evaluation, her CBC was normal except for chronic thrombocytopenia. LFT was consistent with alcohol related to injury. Her ANA, PANCA, and CANCA was negative. Her ABG on room air showed PaO2 of 56 and normal PaCO2 with calculated AA gradient 44. We did CT chest, which showed bibasilar atelectasis and patchy ground glass opacities and mild splenomegaly. Despite being on high flow nasal cannula, she could barely saturate at 90%. This raised our suspicion if she had any shunt that contributing to her hypoxia. We got bubble echo. In our case, it is consistent with extracardiac shunt. On radionuclide scan, which helps in confirming shunt, it involves intravenously injecting technetium labeled albumin macroaggregates that under normal circumstances should be trapped in the pulmonary bed. Scans that identify uptake of radionuclide at the kidney or brain suggest the macroaggregates has passed through intrapulmonary or cardiac shunt. Please look at the image of this patient where I am highlighting. Radionuclide uptake by the kidney and brain. This finding together with the bubble echo confirms she has intrapulmonary shunts, likely due to hepatopulmonary syndrome in our case, which is a common complication in cirrhotic patients. Hepatopulmonary syndrome is characterized by abnormal arterial oxygen concentration, which is caused by intrapulmonary vascular dilatation that which acts as shunt. Most patients eventually present with dyspnea. Platypnea and orthodeoxia are classic manifestations that are specific for HPS. Orthodeoxia, decrease in saturation when patient moves from supine to upright position and is improved by returning to the recumbent position. This finding is due to intrapulmonary vascular dilatation and they're predominant in the lung bases and the preferential perfusion to these dilated spaces in the basal area due to gravity. These patients require long-term oxygen therapy and early liver transplant. Liver transplant helps in resolution of HPS in more than 80% of patients within 6 to 12 months. Patient with HPS waiting for liver transplant has a mean PaO2 decline of around 5 mm per year, which shows that more delay in getting transplant, they keep getting more hypoxic and their ability to tolerate surgery will keep getting worse. Let's see this another interesting point, which looks at 5-year survival. In HPS patient with liver transplant patient is 76%. Versus without liver transplant is only 23%. Based on these studies, transplant societies have recommended HPS patients need expedited referrals for liver transplant by providing them MELD exception scores. What it means is if the patient has a low MELD score but has an HPS, they will get extra points. So they will move up in the transplant waiting list so to increase their chance of getting a transplant. In conclusion, early diagnosis of HPS and early referral for liver transplant can make a huge difference in outcomes as it did in our patient. Thank you.